So we're going to be talking about VADs. Mainly I'll focus on LVADs just because that's the most common. We'll be going over some cases, kind of a brief overview of advanced heart failure, going into what is a VAD, indications for a VAD, the different types of VADs that are out there. And then the part that can be helpful, which is kind of understanding the monitoring and then how to use the monitoring to give yourselves a differential, and then also just looking at patient presentations, and then we'll re-look at the cases. So hopefully we'll be able to get through everything. So if you think about these patients coming in to the emergency department, you have a 48-year-old male brought in by EMS after several syncopal episodes. You look at his vital signs, his heart rate says 173, and they can't measure his blood pressure, and they give you this strip. And then obviously that looks a little bit scary, but you go see the patient and he feels fine, no complications, no dyspnea, no chest pain, no dizziness, no issues going on. And you realize that he has a history of advanced heart failure and a VAD from 2014. Patient 2 comes in, they have a history of a VAD, and they are coming in because their VAD just keeps beeping persistently, but they look alert, comfortable, no distress, can't get a blood pressure. Patient 3 comes in with a VAD and they're weak, dyspneic, they don't look great. They're not actively dying sick, but they just look like they're not perfusing like they should. And again, you can't get a blood pressure. And then the last one would be patient 4, brought in unresponsive, found down, unable to get BP in the field. They're completely unresponsive. So you think about how different these patient presentations are and kind of how you would approach these, and we'll go over them later. This was what his would be whenever you look at it and what you would do in this situation. So how do you approach the VAD patient? It can be very scary whenever you look at it and you're like, I'm not sure what I need to do in order to get this patient better. So advanced heart failure is obviously a big problem. Heart disease is the leading cause of death. 6.5 million people have heart failure in the US. There's about 550,000 new cases each year and 287,000 deaths each year involving heart failure in the differential and the death. Just to recap on how you would treat these people, medical management is beta blockers, ACE inhibitors, aldosterone antagonists. Bidil can be done and has been shown to be a mortality benefit if you can't tolerate an ACE or an ARB. And then you can give diuretics or digoxin, although there is no mortality benefit with these. With advanced heart failure, if they have an EF less than 35%, despite optimal therapy, they do recommend a defibrillator. And then if they have an EF that's less than 35% with a wide QRS, then they have ventricular dyssynchrony, and they recommend cardiac resynchronization therapy, which would be a BiV pacemaker. And that's where they pace both the right and the left ventricle at the same time. In order to do that, you would actually do a coronary sinus. The LV lead goes on the outside part of the heart through the coronary sinus. The main thing to focus on when they would start thinking about advanced therapies is New York classification stage 4, which would be shortness of breath at rest. And your options are home inotropes, heart transplant, or VAD therapy. Intermax may come up, and you may read about that. And the idea is, how sick is this person? If you look at the classifications kind of to the right, and you see that as you get into stage 4, resting symptoms, and then anything 3 and above, you're on either continuous inotropes or you're probably on some sort of temporary cardiac support, and working to see whether or not you're a candidate for either a VAD or a transplant, or something that would be able to keep you going. So ventricular assist device, the definition is a mechanical pump that is surgically attached to one of the heart's ventricles, and then it just augments or replaces the native ventricular function. It has an external power source, and it's connected to an implanted pump by a drive line, which is usually coming out of the right abdomen. Not to be confused with mechanical circulatory support. So while these are ventricular assist devices, they do assist the ventricle. Because they're temporary and they're acute, The better term to use for these is mechanical circulatory support. And you have anything as low as an intra-aortic balloon pump all the way up to VA ECMO. This is what people think of when they think of a VAD. This is kind of the contraption. You'll have your pump that is attached to the heart. You have the drive line coming out of the body. It's going to be attached to a controller, and then that controller is going to be attached to batteries, which are connected to them. And this is how they would walk around and live their lives day to day. An LVAD is surgically attached to the left ventricle and then to the aorta. So it pumps blood out of the left ventricle directly into the aorta, independent of the LV pumping. The RVAD is attached to the right ventricle, and then it's inserted into the pulmonary artery so that it can deliver blood independent of the RV functioning. And then a BiVAD, like the picture shown here, would be whenever you have both of them. Indications for a VAD. So whenever you're talking about putting in a VAD, you'll often see this is the way that they describe it. So it can be a bridge to transplant, which is very common. And they put it in and they're waiting for them to be able to get a heart transplant. The next most common is destination therapy. And I think as VADs get more and more prolonged in their ability that they can stay on, then permanent like destination therapy is probably becoming more common than bridge to transplant, because you can have them for 10, 20 years now, whereas before with what we had, they just wouldn't last that long. Bridge to recovery is an option. It's not that common, but the idea is that you put it in and you just see if they get better over months, as opposed to putting in a mechanical circulatory support and seeing if they get better over days or weeks. And then sometimes you can just do a bridge to decision. You're saying, I have no idea what's going on, but let's just put it in and see what happens. That is not done that often. The most common, again, are going to be either bridge to transplant or just destination therapy, where they're going to live the rest of their life with the device. In 2019, there was 3,200 implanted. 50% were the Intermax profile 1 or 2, so pretty sick. 73% were for destination therapy. So again, we're trending towards more of them being for permanent placement as opposed to bridge to heart transplant. The survival has been really good, 82% 1 year and 80% 2 year survival. So you can see the benefits of being able to put it in if they are a candidate. So whenever you're talking about devices, there's pulsatile versus continuous flow. And in fact, the pulsatile right now just doesn't exist. All the main ones are going to be continuous flow that you're going to see. There probably is some benefits from pulsatile, but they were so big in the early models, they just weren't really useful. And you were able to get much smaller devices with the continuous flow. And there's two types of continuous flow. There's axial and centrifugal. If you look here, the axial flow, you're going to see that it's rotating in there and you're going to be able to get the blood moving forward, versus centrifugal. It's going to kind of spin around and it's going to force the blood into the blood outflow tract. And there's different models on how it is. This is how they look whenever you have them on chest x-ray, and you can see how they're supposed to look with it. So on the right is the centrifugal and on the left is the axial. HeartMate 3 is the main one that's being put in right now. It is centrifugal. It has a magnetic levitation, and it's supposed to be able to be smaller and have less hemolysis, and is now, right now, the only one that's being put in. And it can be for short-term or long-term support. The HeartMate 2 is axial flow. It's not being put in as much just because they've now gone to the next generation with HeartMate 3, but it is used for longer-term therapy, and you will see it out there. HeartWare or HVAD, it was used for a while and had some good outcomes, but they were getting a lot of clotting issues, pump thrombosis, a lot of times where the motor wouldn't turn back on. And so they've actually stopped offering HVADs being newly planted, but there are patients out there that currently have it. These are the adverse events that can happen just by putting in the VAD. So you can see, obviously, there's a high risk to put it in, but there is also a high benefit. But that's why we spend so much time deciding who and who can't get it, because it's not like we just put it in and everything goes fine. There's a lot of monitoring, a lot of complications, a lot of things you need to monitor with them. And we have dedicated VAD coordinators that talk to these patients almost on a weekly basis, depending on how sick they are. So pump monitoring is very important, because you're going to say, hey, this person's coming into the emergency department. What do we do? What are we looking for? What you can see on most of these is that they'll have 4 things that they present whenever you look at their monitor. They'll have RPMs, flow, power, and pulsatility index. If you hook them up to the monitor, which you guys wouldn't have, you'll just have their bedside, they'll have their own like personal monitor, but you can actually hook their personal controller up to a larger monitor. And this is what the larger monitor would look like. But you can get this information from their controller. This is just an easier way to look at it while we're going over it. The first thing to talk about is RPMs. The RPMs is just the revolutions per minute of the pump, and it determines pump flow. If you go up on the RPMs, the pump flow goes up. If you go down on the RPMs, the pump flow goes down. And the RPMs are individually set for the patient, and the patient usually knows what their RPMs are supposed to be and what it was set at. And they can be modified as the patient gets worse or as the patient improves. The team can actually go up and down on their RPMs. The next is flow. And flow is just determined by what the RPMs are. So if you think about it as kind of like part of their cardiac output, it's 4.5 liters per minute or 4.3 liters per minute. It's going to depend on the patient physiology as well as the RPM set. And keep in mind that it's only reporting what the device is doing, not the total cardiac output of the patient. So you can look at it and say, it's 4.5, but the patient could be doing 5.5, or it could be riding it completely and just be at 4.5. So it's just telling you what the actual device is doing for the flow going through it. And the flows can change based on the conditions. So if the patient changes, the flows can drop or the flows can increase even on the same RPMs. And the goal is to set a flow for a cardiac index greater than 2 based on the patient's body surface area. So cardiac index is your cardiac output divided by your body's surface area, and that helps normalize everything. So if your cardiac index ideally should be greater than 2.2 is what a lot of stuff says, but typically we'll look to get it at a cardiac index greater than 2 as a set flow through the pump, and then anything that the heart can do above that can be beneficial. So how do you determine the flow also depends on what the patient does. So you may set it and they could still be under supported. And if they're under supported, you're going to see inadequate perfusion. You're going to see signs of just left heart failure, pulmonary edema, dilated LV, low mixed venous, high lactate. If that's the case, then you probably just need to increase the pump speed. If for some reason you can't increase the pump speed, then you would need to add inotropic support. If you over support them and just turn it up real high and try to get their cardiac index as high as you can to say, oh, well, that's going to be better, higher is better than lower, is that you can actually empty the LV too fast, and it'll send all that blood to the right side, and you'll actually suck down the left side, and you can get what's called suction events, or it can cause arrhythmias because your LV gets so small because you're emptying it too quickly. So you have to kind of find the right balance between being leaving the LV too full and leaving it too empty. Often what they do, and this is all done whenever it's put in and kind of around the time that it's put in, so not necessarily going with what you'll see in the emergency department, but just to keep it in mind, is that they will titrate it based on when the aortic valve opens. If you have too high of VAD flows, the aortic valve won't open at all. You have to have a certain amount of pressure across the LV walls to be able to trigger it to pump well enough to create a pressure to open the aortic valve. And if they do too much, it just won't open at all. It can actually just completely close shut and calcify. versus if it's too low, you can be under supported. So what they often do is they'll titrate the flow so that the aortic valve opens at least every third beat. But oftentimes it will open every beat depending on the patient. Over time, these patients often get aortic insufficiency. And then as you can see, if you have something pumping out into the aorta and you have aortic insufficiency, then you create a lot of mixing, and the blood will just go from the ventricle to the aorta, and then through the aortic regurg will just go right back into the ventricle. And so you reduce its effectiveness, you start getting hemolysis, you start getting pulmonary edema, you start getting a lot of complications. And a lot of times people will eventually get aortic insufficiency. And the reason that it doesn't open, and a good thing here that you can see, is that typically during systole, your LV pressure is like 120, whereas if you look with a VAD, your LV pressure is going to be like 5 or 10 because all the blood's being removed by the VAD. So it makes it very difficult for the aortic valve to open. Power is another thing you'll see. So you'll see it listed there. Patients will know what their pump flows and their pump powers typically are, and that can be very helpful if they're awake and responsive enough to be able to tell you. Although if it's markedly abnormal, you will get alarms. The power is the current and voltage applied to the motor. And so the power will kind of give you an idea of how hard the pump is working. So if you have low flow, but it's not related to the actual rotor or pump, then the power will be low. And then if you have low flow due to obstruction, where it's actually causing the motor to have to work harder, then that power is going to go up. And you'll see that with pump thrombosis is when you'll really see the power go up. And then the last one is pulsatility index. You won't see it on the Heartwear, but you will see it on HeartMate 2 and HeartMate 3. And your pulsatility index, one way to think about it is just how much the heart is contributing. So if you have a high pulsatility index, then that means your heart is beating or contracting fairly well. If you have a low pulsatility index, then your heart isn't very pulsatile, as in it's not contributing very much to what's going on. So it increases when you have preload or contractility increase. So if you were to give them epi and the LV were to squeeze more, their pulsatility index would go up. And then obviously it would decrease if their LV function gets worse. It's not squeezing, it's not doing anything. If you unload the LV completely, the pulsatility index goes down because there's no blood in there for it to squeeze against and create pulsatility. And then you will have alarms. So there's yellow alarms and red alarms. Yellow obviously just means advisory, red means critical. Your yellow alarms are just going to be low battery, or there may be a cable disconnected, or the device isn't functioning properly, but still it's functioning, versus a red alarm would be when the pump is stopped or there's just a system control problem. And that means immediate because it's not actually working, and the patient's going to be in serious trouble if it's not dealt with. So we're going to talk about patient presentations, and hopefully I'll spend some time on this one. I know I've been going over a lot of stuff, but hopefully this will kind of make more sense as we go forward. So whenever you're identifying what's wrong with the patient, your patient presents and you're saying, what's wrong with them? What's going on? What can I do? Is that you can use the pump monitoring to kind of narrow your differential. So we talked about flow, power, and pulsatility index. So the patient can have either low or high flow, low power or high power, and then a low pulsatility index or high pulsatility index. The main ones I'm going to focus on is low flow and high flow, and then we'll also focus on high power. And then I'll just briefly go over the other three after this. So low flow and then suction events would be due to low flow, but low flow is usually due either to a physiological reason where you have decreased preload or not enough volume in your LV, or it's mechanical where you just have an obstruction to flow where you can't get the blood into the actual VAD. Physiological wise, anything that's going to decrease your LV volume. So you can have absolute hypovolemia, as if you have bleeding or dehydration or anything that causes hypovolemia. RV failure, which is very common in people with an LVAD. because oftentimes people that have LV dysfunction also would have RV dysfunction. And if just a LVAD is put in and the RV isn't supported or continues to decline, then you will see some RV failure. And if your RV is failing, then you're not necessarily getting that blood over to the left ventricle to be able to be pumped out. And then anything that would cause obstructive shock is going to do the same thing. If you have obstructive shock, you're not going to be able to get the blood over to the left ventricle. You're going to have decreased blood in the left ventricle. And so it's going to have less blood for the VAD to be able to pump out. And you're going to have low flow because there is no blood to flow through it. And then mechanical obstruction is usually just due to malpositioning with a lot of things. So RV failure, I just kind of mentioned, but as the RV fails, as it continues to worsen, you'll get an increase in RV size. You'll get that rising CVP as there's more and more volume staying in the RV because it can't cross over to the LV. You end up getting tricuspid regurg. The regurg deals with hepatic congestion and liver dysfunction. It also causes renal venous congestion and kidney dysfunction. So you'll start seeing signs of RV failure. You have a super dilated IVC. You have a very dilated RV. You see that the RV is not working. What I talked about in my previous lecture with RV failure, at the bedside, you'll see a reduced TAPSE and you'll see reduced RV function. But the overall result is not only do you get decreased flow to the LV, but because the RV is dilating so much, is it actually pushes that septum into the LV, and it can create a mechanical obstruction because it's pushing that septum close to where the inlet is, and it can cause there to be less flow due to both physiologically with RV failure, but also mechanical. What's going to happen is you're going to get low flow, you're going to get suction events, and then it can cause arrhythmias. There's something unique, and again, you won't be dealing with this unless you go to a VAD center and start working in the ICU, but oftentimes there's a high percentage of these patients immediately post-op that go into RV failure. And this happens immediately after implantation. So much of the time spent pre-op deciding whether or not they should get a VAD is determining if their RV can support the new amount of flow. So if you have somebody that's in decompensated heart failure and they have low cardiac output, and then all of a sudden you put in a VAD and you add 5 liters of flow that's going to be going around the body to the right side of the heart, if the RV is not able to increase its performance to be able to handle that increase in flow, then you're going to go into RV failure. It's going to dilate out, and then they're going to end up having severe complications, and a lot of them die if you can't support the RV until it can remodel and do what it needs to do. And that's because most of them will have some kind of pulmonary hypertension due to their LV function. So they'll have group 2 pulmonary hypertension, and it takes time for that pulmonary pressures to adjust, for the RV to adjust. So much of the post-op phase in LVAD patients is dealing with RV support. But they can also just get RV failure over time as their RV gets worse and worse, just from having all that extra fluid. So anytime a VAD patient comes in, taking a good look at their RV is really important because it is such a high risk of occurring whenever you have these patients. So that, again, this is the normal position. You can see they're positioned really well. They're in the apex of the LV. They're facing up towards the mitral valve. And so you see that they're not going to be pushed up against the walls. Everything looks like they're in a good position. Compare it to here, and you can see how the centrifugal pump on the right is kind of facing more towards the septum. And so they're going to be at very high risk for them to be able to suck up against the septal wall, or they're not going to be able to get flows in because it's not facing towards the mitral valve. And then the one on the left with the axial is that it's kind of off to the side going towards the lateral wall. And again, that's going to make it very difficult to get blood into the inlet, and it can lead to low flow and suction events. Here's an echo of somebody who had their LV is underfilled, and their LV is underfilled because of RV failure. So you can see how big the RV is. It's pushing that septum over to the LV, and the LV is being emptied by the VAD. So it's at even higher risk to have an empty LV. And it's now taken a well-positioned VAD and it's pushed it over into the septum, and it makes it so that you have low flow and heading towards suction events. So anytime you have an LV underfilled, you're going to be at high risk for these low flows. So in this particular echo, it's due to RV failure. So a suction event occurs when there's reduced filling of the pump low enough to have the LV wall occlude the inlet. So the increased negative pressure within the LV, it causes the left ventricular wall to suck over and cover the pump's inlet. The pump then alarms. The RPMs are already set to decrease, and then they'll slowly increase, trying to do what it can and try to maintain the flows that it's set to maintain. Indicators that you're having it is the pump will alarm, but you'll usually see hypotension, you'll see PVCs and even VTAC, and you'll see low VAD flows before as it's occurring, so you know that you're having issues with suction. Here's an example on a heartwear device where they increase the flow. And whenever they increase the flow, it actually caused suction. So you can see on the bottom, they went from flows about 4 liters and they tried to increase it to flows of about over 6 liters. And that was just too much flow. It causes emptying of the LV and it caused suction alarms.
Well, I don't know where to zoom that.
Here's another one that you can see on ultrasound where you can see the LV being filled and fine. And then whenever you have an event, the LV gets sucked down and you end up having the pump get close to the septum and you end up with suction. So treatment for low flow or suction events is treat the underlying condition. If you think it's bleeding, transfuse them. Hypovolemia, give them IV fluids. Oh, sorry, sepsis shouldn't be in there, I apologize. And then if it's RV failure, then if it's RV failure, the idea is you want to make the RV work as efficiently as possible. So decreasing afterload so the RV doesn't have to work as hard. Usually that's an inhaled pulmonary vasodilator. I use inhaled epoprostenol. Decreasing the preload to decongest the RV so it's not pushing over into the LV with diuretics. Increasing contractility just to increase the performance of the RV, and then increasing your MAP, which can help kind of add perfusion and increase the filling of the LV. And vasopressin works well because it increases systemic vascular resistance to increase your MAP, but it actually decreases pulmonary vascular resistance to help the RV. So vasopressin is the vasopressor of choice if you're having RV failure. And then the treatment for both, whether or not it's hypovolemia or RV failure, is temporarily reduce the LVAD speed. So you don't want it to have suction. So if you're having suction events, reduce the LVAD speed low enough, just low enough to stop having the suction events, because the suction events is what's going to cause the arrhythmias, the severe hypotension, and cause the complications. So it's better to just turn down the speed and kind of be underperforming and be have a little bit less cardiac output than what you need, but just to be able to keep those flows up than to try to maintain that speed and keep having suctioning over and over again. So you want to reduce it down, wait till you get everything fixed, and then try to turn it back up. High flow is going to be whenever you have decreased afterload or vasodilatation. There's nothing that it's going to be able to push against. So it's going to be able to go forward very easily. You'll see this in sepsis or distributive shock. If they are taking vasodilatory meds like hydralazine or ACE inhibitors, and if they take too much or something happens, they over vasodilate, that can lead to high flows. And you'll see that occurring. And then vasoplegia can happen, similar to just distributive shock, where you have a huge cytokine release. And then you just get vasoplegia of the arterial system whenever that occurs. The next one is high power. High power, there's really only one differential that you need to focus on, which is going to be pump thrombosis. And this is obviously an emergency. And you look for just signs of hemolysis. So hematuria, elevated LDH, worsening renal function, anything that makes you think that you're having something that's clogging up and that's leading to a lot of shear stress on the red blood cells, leading to that hemolysis. And then you start seeing it in the urine. You know, you have your elevated LDH, decreased haptoglobin. And then oftentimes whenever you have all that hemolysis, it does lead to worsening renal function. The treatment is going to be TPA, is you just thrombolyse them and hope that it will allow the pump to start working again. And then after you give the TPA, you actually follow it with both anticoagulation as well as antiplatelet infusions. So we typically will use a heparin drip plus an integralin drip and keep that on until we see the powers return to normal and see improvement in renal function, improvement in flows and all that. But it can definitely be a problem. It's been more of a problem in the HVADs by Heartware and not as common in the HeartMate 3. But you may see it in these patients because there are Heartware patients walking around. So those are the three we talked about. If you see low power, the odds are it's probably pump failure. And then obviously that's an emergency, but there's nothing that's from like a patient standpoint that's really going to give you low power that's going to cause it, but it can alarm low power, and it's something that you need to look at to see, is the pump failing for some reason? And then low and high pulsatility index. We talked about this earlier. If you're seeing low pulsatility index, then the idea is that you have poor native function, and you have poor native function because either the LV itself is just worsening and unable to contract, or you're taking too much volume out of the LV and it doesn't have the pressure against the walls to create a squeeze, kind of like as it goes up the Starling curve. And you may be over emptying the LV, and you may see that low pulsatility index with that. High pulsatility index, you have your improved native function. That could be, because it can be done for a bridge to recovery, that can be a sign that the LV is just improving. And that means, you know, you have high pulsatility, which means that the LV is actually contracting, it's creating a pulse. Whereas if you had no contractility of the LV, you would have no pulse, and you would just have this continuous flow as they have things with it. Patient presentation. So if you may not have alarms at all, but the patient's going to present with different things. So they can present with worsening heart failure, which is common. They can have cardiac arrest. Arrhythmias are very common, and then bleeding and infection are also very common. So decompensated heart failure, for you guys, it's the best way is just determine, do you think that it's left heart failure? Do you think it's right heart failure? Again, they have a super high incidence of right heart failure. And so it's really something where if someone's coming in with signs of decompensated heart failure, is really getting an echo on them early and saying, is it look like their LV is dilated and that they're under supported and they're an LV failure? Or is their LV actually pretty small and they're actually an RV failure with a dilated RV kind of pushing over into the LV? And that can be helpful. And then once you determine whether or not it's the left or the right, then kind of doing that differential to say, is it VAD related or is it non-VAD related, and working through there. And so if it's VAD related, oftentimes you will see those alarms that we talked about before, versus if it's non-VAD related, you still may see them, chicken or the egg type of a thing, but kind of working through your differentials to say, we know that they're in decompensated heart failure. Let's kind of work through a differential and see where we're at. Cardiac arrest patients are really controversial. If you start getting a lot of VAD patients in your hospital, or you go to a place that has a lot of VAD patients that come in the ED, it's really important that you work with the VAD coordinators and VAD team on whether or not they would want you to do CPR. A lot of VAD programs will say, don't do CPR. Try to just do like chemical coding. Although evidence supports that it's safe and that you can do compressions, but there is some controversy that they're worried that it could dislodge things, and things could obviously go very poorly if you're having chest compressions, especially prolonged chest compressions. Most manufacturers recommend do not perform CPR if the VAD is in place. And then I always say leave it to the clinician's judgment. Have I done CPR on people with a VAD? Absolutely. Temporarily, kind of as things go. Usually once you can get, because they have continuous flow, they usually get return of circulation easier than people that don't have continuous flow with the VAD. So we've done it for a temporary amount of time just to ensure that you're having some flow, because you're really supporting almost the RV whenever you're doing it to get that blood to the LV so that the VAD can continue to work. One thing that people say is maybe you would do it for the smaller devices and not for the larger devices. So the HeartMate 2, it's larger, it's kind of sitting around the area where you would be doing the chest compressions. And so there would be higher risk of you having complications, versus the smaller centrifugal pumps are kind of off to the side, less likely that you're going to have issues with it. But again, you really want to decide kind of as yourself or with a VAD coordinator or with whoever you want to talk about to say, would we do CPR in these people? But have I done it? Absolutely. Bleeding is obviously a big deal. These people are on chronic anticoagulation. So they often come in with bleeding. GI bleeding and intracranial bleeding are both very common. The reasons for it, again, they're on anticoagulation and they have coagulopathies. They can get like an acquired von Willebrand disease. And the most common one is they get these GI AV malformations. So that's really common in terms of an actual disease process, as opposed to just having a high INR when they're on Coumadin. So they get what's called acquired Hyde syndrome. And this occurs in people with severe aortic stenosis, and it actually cleaves von Willebrand factor, and that cleaving of the von Willebrand factor leads to GI AV malformations. So the regular Hyde syndrome is related to severe aortic stenosis. The acquired one is related to having the VAD. The VAD actually causes cleaving of von Willebrand's factor, and it can cause AV malformations. So I always say it's not if the patient's going to get a GI bleed, but when the patient's going to get a GI bleed. They're at very, very high risk for getting one. And then obviously the devastating one is the intracranial bleed that you worry about. And they'll present altered, you get it, they're having an intracranial bleed. And then the question always is, well, what do we do? If you reverse the anticoagulation, they're at increased risk for pump thrombosis. If you don't reverse the anticoagulation, they're at increased risk for increased bleeding into the brain and worse outcomes. So they've done a bunch of studies on this, and they actually have VAD neuro protocols for when you do get an intracranial bleed, and it actually can be safely given. You can give PCC and vitamin K. The PCC obviously is going to immediately reverse. The vitamin K is much longer acting. So if you just give PCC, that INR will drift back up. So it is safe to give PCC and vitamin K in these patients without risk of having pump thrombosis. Arrhythmias is also super common. So in arrhythmias, just treat the patient, not the monitor. They can have really bad ventricular rhythms and actually feel fine. So they can be in VTAC, they can be in monomorphic or polymorphic VTAC, and it won't matter. They're just going to be sitting there. They tolerate it really well because they usually don't need their LV function in order to get forward flow. And they can be completely asymptomatic, and they're just coming in because they just feel weird, or they were told to come in because they see it on there. And you can see that there's an actual high incidence of having some sort of sustained VTAC with people with the VAD. Now, the issue with not treating it is that over time, you're going to have the RV is going to continue to fail because it needs to be in a rhythm to be able to squeeze appropriately. So you still need to treat it, but you don't have to consider it like as much of an emergency as kind of taking your time and realizing it. How do we treat these people either medically or electrically? So you would cardiovert if they're unstable. It doesn't damage the VAD to do any shocks. But look for the cause. So the cause can be due to either worsening disease or it can be due to the VAD itself, like I talked about before. If they're having low flows and suction events, that can precipitate going into VTAC. And then infection, there was one recent article that came out of Michigan that said that they averaged 60% infection rate in the first 90 days. So they just have a huge risk of infection in these patients. And if they do get an infection, their mortality increases like 5-fold over the next 1 or 2 years. The sites that are, there's all the same non-LV sites like everybody else, but they can also get driveline infections as it's coming out of the abdomen. And that's going to be your typical skin flora. And then you can get pump infections where if you get bacteremia, it's going to seed into the pump. If they have a driveline or bacteremia, then it's usually recommended that they get lifelong suppressive antibiotics. And obviously, if you're having just chronic infection that you can't get rid of because of the device, then your mortality is going to be higher. All right, so we're going to look at approaching these LVAD patients. So for y'all, they come into the emergency department, do like you would do everything else. You manage your ABCs, you obtain your IV access, you attach the monitors. You're going to assess perfusion, right? So you're not going to be able to get a pulse in a lot of these people. You're not going to be able to get a blood pressure in a lot of these people. So you have to assess their perfusion using other things. So mental status, cap refill, urine output, and just kind of say, are they perfusing or not perfusing? One thing you can look at, and we talked about lactic acid, urine output, cap refill. You can also look at VAD flows. And for the VAD flows, the idea is, you know, based on their body surface area, if their VAD flows are normal and they're like 4.5, 5 liters, and that kind of gives them a cardiac index greater than 2, and then hopefully that means they're having good perfusion with it. But again, that only tells you the flow through the VAD as opposed to what the actual flow of the person is. And then you want to obtain a map. You can place an A-line, which is obviously the most accurate, and it's usually recommended if you have someone that's sick and a VAD patient. We usually just throw in an A-line just because it's so much easier than trying to be able to get a map. In order to get a map, you actually have to attach a manual blood pressure cuff, and you inflate it to greater than 120, and then you slowly deflate it while you have a Doppler sitting over the brachial artery. And then as soon as you start hearing that biphasic flow or the monophasic flow, then you would say that that's what would be the map. Some people say that may be the systolic, but overall we just use it as the map whenever we would have it with it. But if there's any question or you're having difficulty with it, throwing in a quick arterial line can save you a lot of time of having to keep repeating what the map is, because it can be difficult with the manual cuff and the Doppler. And then after that, you want to really assess the machine. You want to hear that hum. You want to see if there's any alarms, make sure everything's connected, make sure your batteries aren't dead, and then feel if it's like overheating or having any issues. And then you want to assess those parameters we talked about. Look at the power, look at the flow, look at the pulsatility index and the RPMs, and say, is there something that's abnormal? And if you talk to them, a lot of times they'll tell you, this is my normal power, this is my normal flow. Obtaining a bedside echo is really important, and you guys have the ability to be able to do that and feel comfortable doing that. But again, looking at the RV, looking at the LV, the positioning, it can really narrow your differential very, very quickly just by quickly getting a bedside ultrasound on them. And then you want to contact the patient's LVAD team coordinator. So if you're at a site in the future that has VADs and a VAD team, then you would call them. But otherwise, you would just try to find where they come from. And then usually they'll get them transferred over to their center, to their hospital as soon as they're stabilized. So we'll re-look at our patient. So this is our patient 1. And obviously that's a scary looking telemetry where you have your VTAC. But he's in no distress, looks fine. So what's the next step? You do your physical exam. He's in no distress, no modeling, no signs of poor perfusion. His driveline looks clear, no signs of infection. You need to decide whether or not he's stable or unstable. And in order to do that, you get a blood pressure or a MAP. And so we obtain the MAP. His MAP ends up being 45. So now we know that he's unstable because he's now hypotensive with a MAP of 45. So our diagnosis is actually going to be unstable VTAC as opposed to stable VTAC if you had a normal MAP. So if it's unstable, then you're going to do your same thing you would do with anybody else: procedural sedation, cardioversion, defibrillation, whatever you want to call it in this situation, stabilization of the rhythm, and kind of get them supported and look for causes of why they went into an unstable VTAC. Are they having low flows? Are they having mechanical obstruction? Is there some sort of electrolyte abnormality? Just go through your differential on things with that. And then obviously contact their VAD coordinator at their hospital. Patient 2 came in, their VAD keeps beeping. They look very comfortable, but the nurse is unable to obtain a blood pressure. So you bring them in. Again, you're going to go down your differential. She seems to be perfusing, but you want to obtain a MAP. So the first thing you see, and you look at the monitor, is that it's beeping low flow. You get your MAP. The MAP, again, it says 45. So now you have somebody that's hypotensive with low flow. And you want to determine, and they have multiple SI events. So you want to determine, is this due to a mechanical obstruction? Is it due to LV underfilling due to hypovolemia, or is it due to RV failure? Here's our x-ray. It looks pretty good from a positioning standpoint, but where you're really going to be able to get what you need is looking with the bedside ultrasound. So if they had RV failure, they would have a super dilated IVC. You would see signs that the RV is very dilated, pushing over into the LV. Here we can see a completely collapsing IVC. So your concerns is that this is hypovolemia. And so you go down the track of working up just hypovolemic shock that's leading towards low flows. And you send off your basic labs, and she comes back with a hemoglobin of 4, and you find out that she's having a GI bleed. And so once you start giving her fluid and blood, all of this resolves, MAP goes up, SI events go away, and she stabilizes. Patient 3 presents with weakness and shortness of breath. And now they're showing signs of poor perfusion. They're cold, they're mottled, they're uncomfortable, but they're still able to kind of talk. But again, the nurse can obtain a blood pressure. So you're going to, again, go down your way, kind of work your way down, get a MAP, assess the device, look at your LVAD parameters. And you get it, again, MAP's 45, so you know that they're not perfusing well and they have a low MAP, they're hypotensive. And you look at the machine and the monitor, and it says that there's high power alarms. And so high power, you start thinking, well, maybe they're having pump thrombosis, and that's why we're dealing with these issues. So you send off, you find out, you're looking, you put in a Foley, they have some red urine, their LDH is very elevated, and they have an acute kidney injury with a creatinine greater than 3. So you diagnose them as what seems like to be pump thrombosis. They have no contraindications to thrombolysis, so you give them TPA, and you start them on a heparin drip, as well as an integralin drip. And then our last guy, brought in unresponsive, unable to attain a BP in the field. Obviously, they have VFib, and it's going to be up to you. You would proceed with ACLS plus or minus chest compressions. So just to go back over the objectives, we did a brief overview of advanced heart failure. What is a VAD, the indications for a VAD, the different types of VADs that are out there, understanding the monitoring, the flow, the power, the pulsatility index, looking at kind of complications or patient presentations, either using the pump or the patient to develop a differential, and then kind of troubleshooting how we can treat it and go forward from there. And any questions?
Great job, Mike. I have a question for you, though. Is there one echo view that's better than others, considering you have a pump in place there? What's the best way to assess their LV and RV?
I typically kind of just use the normal ones. I haven't done anything differently. Luckily, since most of them have heart failure, it's just easier to see their heart. So I'll do the basic 4. Sometimes it's easier just to try to get the apical 4, just because it's a little bit easier to get that RV into view and really assess the RV, because the amount of times that it's related to RV dysfunction is tremendous.
Thanks, man. Good to see you.
Yeah, good to see you.
Thank you so much. And are there any questions in the room here? Oh, Dr. Willis has one.
Hey, Dr. Ritchie. Hey, Michael. How are you?
Hey, good.
Good to see you. Thank you so much. I had a couple of a quick one. It sounds like the typical workup is usually going to be you can do X-ray, ultrasound, hemolysis labs. Are there any other like labs or something that you send specifically in these patients? I would assume kind of a troponin and BMP are worthless. Anything else that you like typically send on them?
I mean, anytime a bad patient comes in, I always send cultures. I know that's not like as big a stuff for you, but the amount of times where someone just isn't right, and then you find out 2 days later or a day later that they have bacteremia, like it's tremendous. So like even if they look fine, we just culture them up across the board. And it's the incidence of them having bacteremia is really high. And then obviously taking down the bandage and just seeing if they have any drainage from the drive line and really just kind of looking at it from that.
Great, thank you. And then should the expectation be that these patients kind of already had a goals of care conversation, or kind of have the expectations that clearly they have a high mortality when they pop into the ED?
They're supposed to, yeah. I mean, so ideally it depends on the institution, but a lot of them will often have a psychologist that's part of the heart failure team to be able to have these conversations and that they will have goals of care. Now, that being said, have we had patients that came in after 8 years with a VAD and they've been in and out of the hospital, and you try to have a conversation and they're like, no, this is the first time I'm hearing of this. I mean, that still definitely happens, but oh yeah, the amount of stuff that we do to make sure that they understand how sick that they are before they ever get a VAD. They have to have all this social support. They meet with the social support people. They have all these conversations. So that is being done. Whether or not they actually take it to heart or not is another statement.
Yeah, of course. All right, man. Thank you so much. I really appreciate it.
Thanks.
Any other questions?